Welcome back to the channel. In today's video, to prove a point, I had a student I work with take questions from the USMLE Step 2 examination. This is an exam that all medical students have to pass in order to become practicing physicians. I asked him to just give me the HEMONC question, something that I and members of my team have great domain expertise in, because you've got at least 2 card-carrying hematologists, and you've got, actually, I think 4 or 5 attending hematologists, and then maybe about 2 or 3 attending oncologists who attend these meetings, and a bunch of us do both. And you got people from the US, you got people from Europe. So I take those questions, and without ever looking at them, I swear, I just download them right when I go to the meeting. We try to answer these questions in front of a live audience with other attending doctors. And the point of the exercise is to point out that these questions are sometimes okay, but often terrible. They're not the core knowledge you want a medical student to know about hematology oncology. Many of them test trivialities. So we're going to do these questions. We're going to show you what they're getting right, what they're getting wrong, and the biggest problem, that nobody in medicine comes along and says, hey, why don't we have a medical school curriculum that actually teaches people the core of what they need to know to be a practicing doctor, and not random factoids and other bullshit. So you get it live. The end is quite spicy because we all lose our cool over this question. It's so bad. The last one is the worst one. You'll want to see that. Check it out. A live discussion of real USMLE Step 2 questions. All right. Let's take it away. Well, basically, the premise of this is that, I asked Ben Knudsen to put together some slides that he's been using to study for Step 2. These are hematology oncology slides. And now we've got a couple attendings in hematology oncology in our weekly lab meeting. I'm going to show you the questions. I've actually never looked at it. I literally just downloaded it now. And we're going to try to do the questions, and we're going to see what's good about it and what's bad about it. It's going to be fun. You ready? All right. Let's get started. No, shoot, all the Zoom window is on my screen. I can't see the question. Okay. You ready, Milos? You ready, David? They got some attendings here. All right, let's see if you guys know the answer to this. Okay, a 67-year-old woman comes to the office with progressive fatigue and anorexia over the last 6 months. She's lost 4 kilograms, which she attributes to early satiety. First of all, this is a US-based test. Why is it kilogram? Whatever, all right. She has no abdominal pain, no night sweats, no fever. The patient's medical history is significant for hypothyroidism, hypertension, and gout. She does not use tobacco, alcohol, illicit drugs, and is compliant with medications. Temperature is 99.2, blood pressure 128/82, pulse 88. She's slightly thin but well-nourished, mild mucosal pallor, no lymphadenopathy on cervical or supraclavicular chains. Yeah, right, like the doctor actually did that. Cardiopulmonary exam is normal. Spleen tip is palpable. Oh, sure. Like the average doctor palpated that spleen tip. Sure, I believe that. Laboratory results are the following. Okay, hemoglobin 8.6, anemic, platelets 285, leukocytes 42K. Oh boy. Oh, this is such an easy question. Then the fish is back and there's an abnormality in chromosome 22. Which of the following is the most important target in treating the patient's disease? Oh boy. All right. So we all know the answer. But I don't know. It's kind of a stupid question, I guess. Like, this is for medical students. So why do they need to know the treatment? They just need to know, this is USMLE Step 2 question. I think they should know that it could be a neoplasm and that they should do workup for a bunch of things like CML and other myeloproliferative neoplasms and things like that. All right, so the answer, of course, does anyone want to say it?
Tyrosine kinase.
Yeah, tyrosine kinase. All right, of course.
But it's not really a question about treatment, right? A question about treatment would be if they list a bunch of drugs, and then which of these drugs is... This is a pure molecular biology question. You're supposed to know that BCR-ABL is a tyrosine kinase.
Yeah, and that imatinib, which is the first-line treatment. And what's the first-line treatment? It's imatinib. And what if the SOCOL score is high?
I don't think that's a USMLE Step 1 question.
I know. It's still imatinib, god damn it. That's what my point is, that they keep trying to make it this new asimitinib, this garbage drug, dasatinib, garbage. I'm sorry, it's imatinib, low SOCOL, high SOCOL. We've written so many papers on that topic. But honestly, I don't know. First of all, they look at the Philadelphia chromosome. They want everyone to know that. I don't know. I think this question's not a terrific question. Why do they need to know it's a TKI? I don't know. Do they really need to know imatinib's a TKI? That he has CML? I guess the Philadelphia chromosome, CML, and the treatment is... I don't think they need to know that. That's not relevant for... No intern... The only people who need to know that are hemonc doctors who take care of CML. Need to know the treatment. All right. So I would say not a great question for medical students, in my opinion. And first of all, if you show me a student that can actually palpate the spleen tip, I'll give you $100 because I don't think anyone can actually do that. All right, that's some bullshit. If you
I
ask me.
think
All
it's a bad question because it's the type of question you can answer by just reading
the last line.
The last line
Yeah.
and look at that's why it's a bad question.
922 translocation. Yeah. It has nothing to. It's just a factoid. They just want you to memorize factoids. All right. 32-year-old man comes to the ED with worsening pain and swelling in the right leg. Okay. He has no fever, no chest pain, or shortness of breath. He was hospitalized 2 weeks ago for right lower extremity DVT after minor sports injury and discharge on Coumadin. When he left the hospital, INR was 2.2. He's been taking daily warfarin. First of all, what year is this guy getting treated? Coumadin has not been done in a long time. All right, he's taking daily Coumadin. Busy work schedule. His dietary intake is variable, and he missed his clinic appointment for anti-coag monitoring. He has no other medical problems. Blood pressure 120/70, pulse 70, respirations 14. The examination shows pre-tibial edema in the right leg. Today's INR is subtherapeutic. Platelet count, creatinine, liver function within normal limits. Venous Doppler ultrasound shows right popliteal vein thrombus that extends to the femoral vein, and it's worse than on prior ultrasounds. What's the next best step in management? Crank up his Coumadin, initiate thrombolytics, place the IVC filter, replace warfarin with rivaroxaban, start low-dose aspirin. All right. I suspect I know what they're getting at. My guess is they want him to go to Xarelto. I wouldn't give him Xarelto, the shittiest drug. I'd give him Apixaban. I wouldn't give him Coumadin in the first place. IVC filter shouldn't be an answer choice because that's never the right answer. That's a garbage product that was approved through 510K. And thrombolytics should never be an answer choice because last I checked, those bastards have not run a single randomized controlled trial in their whole lives in any setting, and yet they still want to do it all the time. I bet some crazy centers would do it, actually. They would do thrombolytics, or they do catheter-directed thrombolytics some crazy person would do. All right, so my answer is D. Oh, I'm sorry. So the poor Ben. I'm sure Ben knew the answer. He was just clicking through very quickly to give me the slides. Let's see. I don't know. A much more interesting question is what if he was on Apixaban and this happened? That's much more interesting, but this is not that interesting. I guess I'd say this is acceptable for them to know. Acceptable answer for them to know. I'd say, okay, we agree. Thrombolytic therapy is reserved for hemodynamically unstable patients with PE. Oh, yeah. I recall a randomized controlled trial that was negative. I recall a study with submaximal PE that was a bullshit study where unmasking was part of the primary endpoint. You can give it in hemodynamically unstable patients with PE, but it's really a Hail Mary. It's not indicated in this setting. Okay, fine. 44-year-old man comes to the ED with fever, chills, and cough. For the several weeks, he has progressive fatigue and dyspnea to the point that he was unable to mow the lawn last weekend. Patient has no prior medical conditions, no medications, no tobacco, alcohol, or drugs. Temperature 102, a little hot. Blood pressure 100/60, pulse 110, respiration 24, mucosal pallor, scattered ecchymosis. Lung auscultation reveals left-sided crackles and bronchial breath sounds. I'm also not very confident that that's true. No one listened to the lungs that close in the noisy ER. No lymphadenopathy, no splenomegaly, hemoglobin 6, MCV about 100, reticulocytes low, platelets low, leukocytes low. Oh, interesting. Creatinine normal, calcium looks fine, INR fine, coags fine, LDH low. Left lower lobe consolidation seen on chest x-ray. Blood smear shows decreased leukocytes, erythrocytes, and platelets, otherwise unremarkable. What's the most likely diagnosis? What are the choices? My Zoom screen is on there. Shit, I knew the answer. Is aplastic anemia. The other ones were bone marrow myelofibrosis. I was trying to move my stupid Zoom thing and accidentally triggered the answer. All right, sorry. No, it's not B12. I guess a good B12 question is when they also get hemolytic anemia from profound B12 deficiency. That's something that people should know. I think this is not myeloma, not hairy cell. It's easy. I don't know. It's fair for them. This is a fair question, I think. Everyone should recognize aplastic. Usually when I do leukemia consults, I get called in the middle of the night with this case, and then they say the patient has acute leukemia. And I say, wait a second, actually. They actually don't, but I'm happy to take your consult. And I would just say, we'll just work on the transfer. That's what I like to say. All right. Are you having fun? This I think we're going to have some anger when I already looking at the answers. I know I'm going to get angry with it. Okay, 66-year-old woman comes to the office with 2 days productive cough, low-grade fever. She's had community-acquired pneumonia, sinusitis 2 months ago. Review system's positive for fatigue, weakness, right-sided chest pain. Otherwise healthy, takes no medications. Never smoked cigarettes, drinks alcohol only on rare occasions. She's hot, blood pressure 126/72, pulse about 100, respiration 16, pulse oximetry 96%, well-appearing, mucosal pallor. There's no lymphadenopathy in the cervical or supraclavicular chains. Bronchial breath sounds and crackles are in the left lower lung field. Point tenderness over the ribs. The abdomen is soft, no splenomegaly. Hemoglobin is cough, low-grade fever, pneumonia 4 months ago. Hemoglobin is 9.4, MCV 88, platelets 235, leukocytes 13.5. Chest x-ray show consolidation in the left lower lung and right-sided osteolytic fractures at the 7th and 8th ribs. She had increased risk of recurrent infections due to which of the following abnormalities? The fuck question is this getting? A complement deficiency, membrane attack complex defective, destruction of CD4 lymphocytes, impaired chemotaxis, impaired antibody production, impaired phagocytic oxidative metabolism.
I think they're
So
pointing
it's
to a
myeloma. What's that? Huh? It's myeloma.
Yeah, myeloma, yeah.
Okay, so then myeloma, and then she has immunoparesis, so she has low antibodies.
It's the impaired effective antibody production, maybe.
I think that's what they're getting at. But is that a good question for a second year for a medical student? I don't think so.
It's again the same problem. A lot of information that is unnecessary. If you just read the last phrase, then you can get the answer. So
you're right. You know she's got osteolytic lesions, and she's got these counts, so that's myeloma, probably. It would be interesting if it's actually, you could think of something that's not myeloma that would cause this picture, wouldn't you?
Yeah, of course, yeah.
Yeah, she's got a solid tumor malignancy, and
correct.
she happens to have a lot of marrow involvement, or she's another reason why the marrow's failing. I think this is not a great question. It's not a great question for students. For students to know that immunoparesis is a myeloma-related event, I think is not the most interesting thing. I veto this question. Yeah, myeloma, blah, 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 blah. Hypogammaglobulinemia. I don't know. Lots of heme malignancies have lots of different reasons why you're susceptible to lots of infections. Knowing exactly which one has which mechanism is irrelevant for most doctors. Bad question. I mean, it's a fine question for us, but bad for them. And actually, let me push you on that. Although myeloma patients have immunoparesis, if I really put a gun to my head and asked you what study proves that that's the reason they're susceptible to infections, I can't name a study. What do you think, Milos? Really? Right? If you really push comes to shove.
Yeah, but this isn't a reality-based question. It's a buzzword-based question. You're supposed to connect a string of buzzwords that'll get you to the right answer, not really know clinical medicine.
Yeah. And that's why I'm making this video, because I want to say, like, these people who write these questions, they're so lazy. They just write this bullshit. The questions we did yesterday were even worse. There was so much bullshit in there. There was one question yesterday, I got to say. Somebody had like testicle pain and the answer was torsion. But in the question, if you lift up the scrotum, the pain doesn't get better. So if you lift up the scrotum and the pain gets better, that was called Friend's sign or something. That's epididymitis. And then if you lift up the scrotum, the pain doesn't get better, that's torsion. And my first gut reaction was that's gotta be 100% bullshit. That sign has to have like the worst test characteristics. And then we looked it up while we did this, and lo and behold, it was 100% bullshit. It had the worst test characteristics you could ever imagine, and you should never use that to decide. And yet that was baked into the question. These questions are all stupid. All right. Yeah, I think just because you can get it doesn't mean it's useful. These tests should be written from the point of view of like, what do we want most people to know? All right, we'll do the last one and then we'll just reminisce about it. Also, where's a solid tumor here? Why is it all heme malignancy? 55-year-old woman comes to the office with 3 months of night sweats. I can't see it. My Zoom thing is blocking. I can't read those words. Oh, she's tried using a fan and sleeping without a comforter, but she continues to awaken several nights with the bed sheets so drenched she has to change them. Okay, I will say, there's one good point. When I talk about night sweats, I always ask my patients, do you have to change your shirt or change the sheets? Because everyone sweats at night, but until you're changing your shirt, in my opinion, it's not a real night sweat. During this time, she has unintentionally lost 11 pounds. She went to Vietnam with her church group 6 months ago and wonders if she may have caught something. She took her anti-malarial pills and received her pre-trip vaccinations as recommended. She probably got her COVID booster too. and has not had any fevers. The patient does not use tobacco, alcohol, or illicit drugs. 99.4, blood pressure 144/78, pulse 96, pale mucosa, no scleral icterus. I'm also suspicious that anyone actually is looking at that properly. There's no cervical lymphadenopathy. Cardiopulmonary exam is normal. Spleen tip is palpable when she exhales completely. Impossible that anyone is actually doing that correctly. Laboratory results are the following. Hemoglobin 8, platelets 6 hundos, leukocytes 66, neutrophils, bands, eos, bezos. Oh. That's interesting. Which of the following is expected in this patient? Absence of measurable erythropoietin, decreased leukocyte alkaline phosphatase score, positive acid fast stain in the blood, positive Coombs test, positive Giemsa stained blood smear, presence of Auer rods. All right. So, what do you think?
I'll go with the C. I think it's CML.
CML. I think it's CML too. But you're going to go with C?
Yeah.
Acid fast? Positive acid fast. What do we I thought acid fast is for hairy cell leukemia and tartrate, whatever, blah, 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 blah.
So, but if you exclude all of them, so it's not erythropoietin, it's not a decreased leukocyte alkaline, maybe it's increased.
What about
positive acid phase? Maybe Coombs test, it's not positive in CML. It's CLL. Giemsa stain, maybe. Our rods you don't have in CML. So.
I agree. It looks like CML, but it also, truth be told, it could not be. It could be something other than CML. She could just have reactive platelets because she has like iron deficiency, and she could have like leukocytes. She could have CLL with like a Coombs positive CLL causing a little bit of hemoglobin. Plus, she has iron deficiency anemia and other reasons why she has reactive platelets. So CML is not a slam dunk, but I agree with you. It looks like CML. I mean, this is CML, but I'm not sure. I don't know the answer. David Benjamin, you know the answer? You know the answer, Milos?
I've been cheating since the first question. I've been plugging in the questions into ChatGPT or O, and so far it's gotten every answer correct with a pretty good rationale, and it has an answer to this one. And I would not have known it, but do you want me to tell you what ChatGPT thinks it is, or do you want to figure it out yourselves?
I want to think about it more. Don't tell me yet. Okay, so David Benjamin, any thoughts?
Well, as somebody who's not the hematologist, I'll say, yeah, CML did come into mind, but I don't know. I agree. Even if we go through the process of elimination, maybe, it could be some leukemia. Maybe if it's CML and blast crisis, you could argue F, but I don't know.
Yeah.
It's not the best answer.
I know. CML, the problem with CML blast crisis, there's no blast in the blood, so it's not accelerated phase. Yeah. It's not blast phase. Our rods, could it be APL? No. I mean, if it's APL, we'll have blasts. Leukocyte alkaline phosphatase score? What the fuck? I've never found that to be useful. Measurable erythropoietin absence? Oh, I guess. No, EPO should be high. Now, could it be an infectious thing? Could it be like, could it be EBV, acute EBV? I think that's also possible. I mean, the reality is in real life, the differential is still quite broad. I don't want early closure. I'm not going to call this patient CML until I get a BCR-ABL. I think I'd want to look at the smear. I'd want to order a bunch of blood tests. I don't know. Let me guess. So you're going to go with acid fast stain? I don't think that's it. I think that's looking for some.
Yeah, I think they're looking for TB with the acid fast, and I think that's the other infectious thing they're trying to like put on the differential, but and with like her Vietnam history and stuff. But I don't think that's really what they're getting at.
Coombs. I think Coombs is Giemsa sustained our odds.
You're overthinking it. It's not clinical medicine. It's not a clinical question. It's a buzzword question.
All right. So, well, let's look at the answer. Well, tell me the answer. What does ChatGPT say?
ChatGPT says that out of all of these tests,
decreased leukocyte LAP. That's what I'd guess.
Is really the only one that has connection to CML. So,
what the fuck? Stupid question is this?
So useless test. with useless test characteristics, but ChatGPT 401 Vinay 0.
Well, you know what? The people who write this test are the dumbest fuckers. I'll say this is a dumb fucking question. There's never once in clinical medicine that the lap was ever useful, and I did not know that because I have access to BCR-able PCR because I'm not running in the most antiquated hospital on the planet Earth. And
it's not a reality-based question. It's a buzzword-based question.
All right, we're gonna stop.
I doubt anybody. I sincerely doubt that the person who wrote this question has ever seen a patient with CML outside of med school 30 years ago. That's
this is so fucking stupid. So
I sincerely doubt it.
So we got our ass handed to us on the last question. But this is a great example. We are not teaching these students, this is like to be paired with my essay on like how we're screwing the students over in my like medical school. We're not even testing on relevant things. Did anyone know that answer? Honestly? Not even the students who are smart? Man, I didn't know. I got crushed. And Vadim's a hematologist too. We got two hematologists. And you're a hematologist, Milos. You're a hematology attending too. They're getting crushed on this. It's so disconnected from real life. And to be honest, you make a great point. If its lap is low or high, it could be either one. Actually, it could be leukemoid or it could be, it could be either one. It hasn't done anything for you. This is garbage. All right, we're going to stop the recording. The point is well taken. The point is the USMLE, like the ABIM, like all these predatory companies, their primary goal is to take money from doctors' pockets and to provide a little fake license that you're certified to be a doctor that has nothing to do with actually being a doctor. And this question is a great example where the more the lap is in your brain, the less useful things are in your brain. And you really miss the plot. And lap. All right, we're going to call it. All right. Well, thanks for playing my little game. I'm going to stop this. Okay. As you were saying, yes.
Yeah, it's the same stuff that you learn in med school. It's all the stuff, all these facts that you bash into your head with Anki cards and all this nonsense. And then you travel for the half of fourth year when you're done, you already match, and then you forget everything. And then you go into intern year, completely dumb as rocks, how to, do clinical medicine. And that's just what is expected. That's part of the path, as they say, it's just bullshit.
It's just bullshit. And then I don't know. I think you start to learn some clinical medicine in intern year and residency and some in fellowship, but literally, for me, the most common thing is I don't know, we have a simple question in clinic. Should we start the person on imatinib, dasatinib, nilotinib? And literally, we have not trained anybody who's graduating. I think 1% of fellows graduating are equipped with any tool. How do you even think about that question? Oh, I'll look at NCCN. Okay, defer to experts. Is that the level we're operating at? Or can you read the literature, argue, make an argument? That's what medicine really is. To argue why someone should have something, why they shouldn't have something, argue what you should do. We don't give anyone any of those tools. We're teaching them all this nonsense. And you're right. I completely agree with you. All right, we're going to stop this and go back to our real meeting. It's really, really bad.